Warm welcome to the first IPNFA online congress. My name is Benedikt Böhmer and it's a big honor for me to be one of the speakers on this congress. Before I start my lecture, I want to introduce shortly myself. I'm coming from Berlin, a beautiful city. I have to say, if you have never been there, I strongly recommend after the pandemic to go there. I start my professional life as a physiotherapist in 1989, so now more for 32 years. And I'm a senior supervisor in the neurological rehabilitation clinic in Belitz. This is nearby Berlin. This is the main entrance of the rehabilitation clinic, beautiful building, and we have around 250 beds with three main departments, one for stroke, one for traumatic brain injury patient, and then one for spinal cord patient. In my postgraduate training, for you it's interesting that I'm a PNF instructor since 1999, I'm a Bobert instructor since 2003, and I did my Master of Science for Neurorehabilitation at the University in Krems in 2014. Now you know a little bit my background, and of course there's more than only my professional life. I like sailing during summer and I love snowboarding during the winter. This is the best. Now enjoy my lecture. I want to show with my lecture the treatment approach with PNF for patients with a neurogenic dysphagia. The content of my lecture will be, after a short introduction to dysphagia and aspiration, I want to explain clinical reasoning, and then for the treatment approach with PNF I have some patient examples, and I want to discuss with you the importance of positioning and supporting of cuffing, and at the end of my lecture I have a small take-home message. The dysphagia is a neurogenic blind. In case of a neurogenic dysphagia, the oral and or pharyngeal phase of swallowing is affected. We have two main swallowing phases. At first, the oral phase. The oral phase is divided in two subphases: the oral preparation phase and the oral propulsive phase. In the oral preparation phase, we taking a bite and take the food in. The main activity is here chewing motion with closed mouth until the correct consistency is reached. In the second oral phase, in this oral propulsive phase, we transport the bolus or the food with the tongue to the soft palate. The tongue is moving to anterior and then to posterior, and this is important to trigger the pharyngeal phase. The oral phase is under voluntary control. Comparing to the next phase, this is a pharyngeal phase, and this phase is not under voluntary control. In a very short time, we have a high neuromuscular coordination, and therefore we need our central pattern generator for swallowing. You see this long list, what's happened in less than 1 second. The consequences of a dysphagia are malnutrition, dehydration, penetration aspiration, aspiration pneumonia, trachea tube and tube feeding, and then, of course, reduced quality of life and also death. The main patient population are stroke patient, patient after traumatic brain injury, morbus Parkinson patient, multiple sclerosis and spinal cord injury patient. In the acute phase of stroke, more than 50% suffering under dysphagia, and within 2 weeks, 25% of them pass away. So it's a very important topic in the acute rehabilitation after stroke. But still, around 25% in our chronic phase after stroke suffering under dysphagia. So Also, with this patient, we have to consider this topic. By a lesion in the area of the brainstem, 80% of the patient has a dysphagia, and this is logical because the anatomic structure for swallowing is located on the brain stem. 65% of them had already an aspiration, and important to know for you is more than 2/3 of all aspirations are silent, so-called silent aspiration. That means the relatives and or the patient does not realize that there has an aspiration. Now I want to explain what is an aspiration and what is the difference between an aspiration and a penetration. If you're looking on this anatomic picture, you see this white line. These are the vocal cords. An aspiration is if food, saliva, liquid is below the vocal cord and you have all negative effects of a lung inflammation. Comparing to a penetration, food, saliva, and liquid penetrates the vocal cord. So food and saliva is above of this vocal cord and the lung is not affected. But you can hear it. Normally, if the patient is talking, then he changes his voice, and we call this the so-called wet voice. Screening assessment. What you can find in the literature, what kind of test has really evidence. Here we have this standardized swallowing assessment and the gagging dysphagia bedside screening. Both of them have a very high sensitivity, so you know that the patient has a dysphagia, but you don't know the reason of the dysphagia. And then, of course, the doctors do all this medical assessment. After the discussion about dysphagia and aspiration, I want to shortly explain clinical reasoning. In our PNF philosophy, we have our assessment, and to figure out why a patient is not able to do a specific activity, we use a clinical reasoning process. That means, what means clinical reasoning? This is a decision-making process for the therapeutic approach under the aspect of evidence-based medicine practice. Means best knowledge, best evidence, and best clinical experience and skills in order to know what to do. Now, we talked already a little bit about the phases of swallowing. I gave you an overview about dysphagia and aspiration. Now we're looking shortly what are the best evidence if the patient is suffering under dysphagia. And here I found in the literature the functional dysphagia therapy. The functional dysphagia therapy is mentioned in the guideline German Association of Neurological Rehabilitation 2015 as the best therapeutic approach with dysphagia patient. This functional dysphagia therapy has 3 items: restoring, compensatory, and adaptive. Restoring means facilitation of all muscles which are necessary for swallowing. This we can use mainly if the patient has a limitation in the oral phase. Compensatory strategies, that means the patient has to learn different new swallowing techniques. We use mainly if the patient has a limitation in the pharyngeal phase. In the PNF concept, we start the assessment on the activity level, and the first step is to start with the interview to figure out if the patient had or has some symptoms of dysphagia in his history. After this, we analyze posture and movement, and especially in the facial oral tract, we are looking on the face symmetry. We're looking about chewing, tongue and cheek movement, and testing the intraoral sensitivity. What are the typical symptoms of a dysphagia? The specific symptoms are prolonged oral phase, coughing or choking with swallowing, difficulties to initiate swallowing, or the patient has a feeling the food is sticking in the throat, and we can see drooling. Unspecific symptoms could be unexplained weight loss, change in the diarrhea habits, recurrent pneumonia, and change in voice of speech, the so-called wet voice. Now, after my explanation about clinical reasoning, I want to start with my patient examples. My first patient example is a patient with a limitation in the oral preparation phase. Mrs. M was diagnosed with a Pons infarct in September the 10th in 2009, and the result of this was a proximal ataxia, a tetraparesis, and a dysphagia. If you're looking now in our assessment, we see she is independent in the ADLs, but she has a limitation in the oral preparation phase. So we're looking shortly on a video that you can imagine how she's moved the mouth. I ask her, what day is today?
Wissen Sie, welcher Tag ist denn heute?
Gehen wir auf die Büro.
You can see there's not enough
Welcher Tag?
chewing motion, and there's a lack of cheek motor activities, and she's not able to open the mouth sufficiently. My hypothesis on the body structure, body function level is she has a weak hypotone facial muscle on the left. She had a weakness hypotone temporomandibular joint opener on the left side. So her left side is her weak hypotone side. And she has an hypertone tight muscle masseter and temporalis on the right side. And this is the reason that she has a limited range of motion in the TMG on the right side to open the mouth. Now, in the clinical reasoning process, we know the phases of swallowing and dysphagia, only as a small reminder. So our patient, she has not enough mobility in the TMG for sufficiently chewing motion. Then, next step is, what's the problem? She has a high risk of aspiration before swallowing because she has a disordered oral motor activity. If you're looking now in the evidence, is there some treatment approach for facial palsy? And if you look in the literature, the evidence for various physical therapy in patients with a facial palsy is lacking. In my clinical experience, I can say also the patient with a facial palsy has a benefit of our therapy. Is there some evidence for mobilization of hypertone muscles? Yes, there is. PNF stretching is positioned in the literature as the most effective stretching technique when the aim is to increase the range of motion. Now, through the therapy. I was choosing from the PNF concept from the basic principle verbal, tactile, and resistance and approximation, and from our vital function, I'm using facilitation of the mimic muscle and to mobilize chewing motion. Now we're looking in this treatment approach in. At first, I start with the facilitation of the risorius, that she can move the cheek. I do this passive at first and a little bit assistive. Then I try to facilitate the levator labii, also for her to move the mouth and that she has more facial expression. Now I take this muscle with my hands from both sides, from out and inside of the mouth, in order to get a better proprioceptive stimuli and on the biomechanic aspect that I have the muscle from both sides in my hand. Then facilitation of the orbicularis oris, so that she has also more mobility in her mouth and selective movement. Try to give a small re-stretch for this orbicularis oris. Now, the mobilization of the TMG on the right side. I'm going with my thumb in the mouth and with the left hand, and with the right hand I going with my fingertips on this hypertone temporalis and masseter. I ask her to hold this position. I try to open the mouth, so she has to contract this hypertone muscle isometrically. After this, I will ask her to relax. After the mobilization of the hypertone muscle, I try to facilitate the new range of motion. Remember, I said she has also weak mouth opener. So now I facilitate the mouth opener in order to get more active mobility in her TMGs. Using the technique dynamic reversals at the end, so that she has to activate both muscle groups which are necessary for chewing dynamically. My next patient example is with a patient who has a disturbance in the oral propulsive phase. This is Mr. S. He's 68 years old. He was diagnosed with multiple infarcts in July the 3rd in 2017. The result is that he has also a pons infarct from both sides, with a hemiparesis on the right side and a dysphagia. Now, if you're looking in our clinical reasoning process, we know already the phases of swallowing. As a small reminder, he has this limitation in this oral propulsive phase, and here was important that we have enough selective movement in the tongue and enough muscle power. This is important that I can trigger the pharyngeal phase. Here the high risk is the aspiration during swallowing because of the weak retraction of the tongue and less strength of the suprahyoidal muscles. In evidence, we can say improvement of posture control running parallel with a significant improvement of oropharyngeal motor dysfunction. This is important to know because my patient, if you're looking on the alignment in sitting, is also affected in his posture control. He's sitting asymmetrically. His center of mass is more passive on his right hip. If you're looking on his right trunk, it's longer the right side, and he's sitting passive on his right hip. If you observe him, also he's asymmetrically from sit to stance and doing stance phase, so he's not enough weight bearing to this side, and he shows associated direction during movement against gravity force. If you're looking on the midline, you can see clearly that his right side is longer than his left side. My hypothesis here is that he has a weak transversus and a weak gluteus maximus medius minimus. So we can say this patient has also limitation in posture control. How I can facilitate posture control with PNF? In my clinical experience, we can use the stages of motor control and the principle of motor learning, and here I use task, environment, and shaping. Now, the treatment approach with PNF. At first, to improve posture control. Here, I use at first on his left side, the left arm, the pattern flexion, abduction, extrotation in order to get on his right side the transversus activity. In PNF we call this irradiation, and also this is one of our philosophy, how I can use the non-affected part of the body to facilitate the more affected part of the body. I give him a slight resistance against this movement to facilitate or to get more motor units on his right side. My left hand is now giving a proprioceptive tactile stimulus on the muscle belly by himself. In the next step, I give him a task for the upper extremity to hold this chair in order that he's not using the arm for compensation of posture control. At the same time, I use the same pattern, and in PNF we call this mobility on top on stability. Now I facilitate weight shifting to the left side with the pelvis pattern anterior elevation, also to get more activity of his transversus. At the end shaping, I try to ask him to lift up this left arm in order to get more motor units. Because of didactical reasoning, I showed you at first the assessment of posture, control of my patient, and then the treatment. The next step in my assessment is to assess his tongue movement, because I know the tongue movement is important for the oral propulsive phase. If you look on my patient and you see how he's pushing forward his tongue out, you see that the tongue tip is moving to his right side. So I can say he has a lack of selective tongue movement as a limitation in his facial oral tract. He has a lack of tongue retraction movement, and this is the reason that he has a lack of initiation of the pharyngeal phase. The hypothesis is that he has a weak hypertoned tongue on his right side. He has a weakness of the suprahyoidal muscle on his left side, and he has a small deficit in his intraoral area. First, I want to show you how I will facilitate the suprahyoidal muscle group. There's clear evidence that if you facilitate and strengthen the suprahyoidal muscle, this improves swallowing. How I can do this with PNF? Now, if you're looking in PNF, I can use here the neck pattern, because the neck pattern for flexion activate all flexors of the cervical spine, and this is a combination from the suprahyoidal muscle group and the infrahyoidal muscle group. How it looks. At first, I have to optimize the upright position to bring him in the best alignment to make swallowing easier. First, I activate his extensors. Now I'm using approximation through my hand of his head in order to activate all postural muscles. After this, I will start with the neck pattern to his right side. At first, passive and assistive. I'm standing behind him to give him with my body, with my legs, enough postural stability. After this passive assistive phase, I resist this movement. I ask him to look to his right side, because if I use his visual system, I get more on his ventral activities. And again. Okay. After the neck pattern, this is more a global activity of all flexors of the cervical spine. I want to work a little bit more specific. And then I can use also jewing. So if I facilitate the opening of the mouth, I facilitate also the suprahyoidal muscle, because the suprahyoidal muscle has three functions. It's elevate the larynx, it's open the mouth, and it flex the cervical spine. So I'm using now the activity open the mouth in order to facilitate the suprahyoidal muscle. And this looks like this. At first, I stabilize with my hand the hyoid, the larynx, to give the suprahyoidal muscle group a punctum fixum, and that make it easier for the patient and for this muscle group to be active. Also, at first, I show the movement, and then I start directly with resistance, concentrically and eccentrically. The technique is called combination of isotonics. Of course, I have always to observe that the cervical spine is in a proper alignment. The next step in my treatment is the facilitation of the tongue. So, you see, this is an example. At first, we start with global movement, and then we're going more and more to the specific problem. In the literature, it's written isometric, isotonic exercises for the tongue improve muscle power and improve swallowing. And in PNF, we have under this facial oral tract also the facilitation of tongue movement. And it looks like this. I take the tongue in my hand and I show him the movement to push the tongue out and move them backwards. Backwards and out. Backwards and out. So I give him a resistance for both directions, and I try to emphasize also both diagonals. At the end of my treatment, I start with this intraoral stimulation with eyes. Also here we have some evidence. Eye stimulation within the oral cavity increase the excitability of the cortical swallow motor pathway. And with PNF, I can use this intraoral stimulation, and this looks like this. First, I show the patient this ice tube. Now, what's going on? Then, at first, he starts with sucking the eyes to stimulate at first the lips so that you get used to this cold stimulus. Right after, I ask him to swallow. Then I give on different spot on his tongue and also inside of the cheek a sense torque stimulus, also in order to stimulate swallowing. Again, I give on the soft palate and in different spot this stimulus, and he has now to follow with his tongue the eyes stimulus in order to improve selective movement. And you see, we have also some fun. At the end of each treatment, we should check if the patient had some benefit of my treatment, so we have a clear documentation in our PNF concept. And at first, we're looking on the posture before, and now you see the posture after my treatment, and you can see his midline is really in the midline, and his center of mass is more in the midline, and his right long side is now more symmetrically. If you're looking on the tongue deviation before, and now the tongue deviation after, and now you can see he's after the treatment, he's able to bring the tongue straight forward. I want to discuss with you the importance of positioning and supporting of cuffing. We can say the treatment of patients with a dysphagia is a big challenge for an interdisciplinary team, especially in the acute phase. Besides the functional dysphagia therapy, also positioning and facilitation of breathing and supporting of cuffing is important. At first, therapeutic approach in the acute phase. As far as the patient has no head control, The aim of the treatment is to activate the brainstem function to optimize the requirement for swallowing. During standing in an upright position, we stimulate the patient unimodal or multimodal. It looks like this. To enhance the brainstem function, we give a strong proprioceptive input to increase the awareness of the patient and to facilitate the anti-gravity muscles. And this we do in combination with an unimodal and multimodal intraoral stimulation. I brought one patient with me, and this is a patient after traumatic brain injury without any head control. The occupational therapist stabilizes the patient from behind. The physiotherapist is guiding the teeth brush. So we use standing in order to use the gravity force, and we use for intra-stimulation the teeth breath. Now to positioning. The optimal position for a patient with a dysphagia is 45 degrees upright with a neutral position of the cervical spine. To minimize the complications, especially aspiration and aspiration pneumonia, to provide postural stability, especially for breathing, and to give more stability for the insertion of the diaphragm. And of course, positioning is also a pneumonia prophylaxis. Important here is that we have to change the position every 2 till 4 hours. Why positioning is so important? On the left picture, you see the patient without any transversus activity comparing to the right side. If you're looking on the diaphragm on the left side, this is already in an inspiration position. So that means the patient without transversus activity is not able anymore to inhale enough comparing to the right picture. Here you see that the diaphragm is in a neutral position, and this is biomechanically the requirement for breathing in and out. This is the reason that we need always a belly belt with our patient to stabilize the trunk in order that the diaphragm is able to work. We need therefore pillows, blankets, and blocks. Important is that every part of the body is supported or stabilized to avoid any compensatory fixation with the upper motor neuron syndrome. Here is the optimal position. As I said already, there's already also evidence for. That's the 45 degrees upright sitting position is beneficial for patients with a penetration or aspiration. Important is that we avoid hyperextension in the cervical spine. Therefore, you should support the cervical spine with a towel. Because if the cervical spine is in hyperextension, we have a high risk for aspiration. Maybe shortly you do this by yourself, going in a slump position in sitting, go in hyperextension in your cervical spine and try to swallow. And then you feel biomechanically how difficult it is. Important is also the positioning in the wheelchair, because mainly our patients are lying backwards. And again, here the patient will have a hyperextension in the cervical spine. So important is the patient needs a table in front with a big blanket in front to stabilize the shoulder girdle. Then a second pillow on one side that he can put his head on this pillow for resting. And we need a blanket in front of the belly to stabilize the trunk and that the patient is not gliding forward. At the end, we can check shortly the tube, and then the patient can relax and there's no risk for aspiration anymore. After positioning, I want also discuss with you facilitation of breathing and supporting of coughing, and here I want to highlight the importance that we have to support coughing. There's also some evidence. It means to increase manual the intrapulmonary pressure to support coughing is helpful for the patient. In PNF, we have a facilitation of breathing and coughing, and it looks like this. I'm working here with a nurse together. She is sucking out the sputum, and in the moment where I feel the cough reflex, I support manually the expiration in order to increase the interpulmonary pressure, that the sputum is moving cranially, so that the nurse is able to clean not only the trachea, so that she's also able to get the sputum out. Here we need a good teamwork, and you see here's one of the examples what I said at the beginning, that an interdisciplinary approach is necessary for this kind of patient. At the end of my lecture, a small summarize, a take-home message. Please check always the 4 signs of dysphagia: drooling and or permanent drooling, saliva swallowing not possibly, always difficulties, coughing or choking with swallowing, voice change after saliva swallow, or permanent voice abnormalities. Positioning was important. Here I highlight to avoid hyperextension in the cervical spine, eating and drinking always in an upright position, emphasize breathing and coughing to prevent pneumonia, and in the treatment I showed, for example, in this oral propulsive phase, strengthen postural movement of the tongue, facilitation of the suprachoroidal muscle. Here is a short overview about my literature. Thank you for your attention. I hope you enjoyed the lecture on our Congress. Please don't forget to be in the lives with the speakers tomorrow. If you have any question or suggestion or comments, please leave them below in the box. Thanks a lot. All what you saw was a part of our curriculum of PNF Level 4 neurological course. So if you're interested, maybe we meet us there. Or latest, we see us in the lives. Thank you very much. Bye bye.